Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Sunita Chandra ma'am. And let me share some of the achievement of ma'am. Ma'am has done MBBS, MD in OBGY, FICOG, laparoscopic surgeon, OBGY, and reproductive endocrinologist infertility specialist at Rajendra Nagar Hospital, Rajendra Nagar National Clinical Director of Marcophilus IVF. And today, ma'am is going to discuss on a very important topic, that is endometriosis and its impact on fertility. To know more about this topic, I would like to invite ma'am and hand over this session to ma'am. Over to you, ma'am. Kindly proceed from here.
So thank you so much. Thank you, IGCP, for giving me this opportunity again to be with you live on this show. I don't remember exactly how many shows I have done, but yes, I'm quite frequent on this platform. So thank you so much and welcome all the delegates with me. I am here from Lucknow, Dr. Sunita, practicing for 30 years now and a hardcore infertility specialist, that is IVF and infertility, everything I do. So that's all about me. I'm in Lucknow. I bring greetings from city of Nawab, that is Lucknow. And today we'll talk about endometriosis, its impact on fertility. So endometriosis, all of us know it's a chronic disease, it's a bad disease, and is associated with severe life impacting pain during periods, maybe during intercourse, that is dyspareunia. Patient may be having problems passing urine, passing bowel movements. She may have chronic pelvic pain, abdominal bloating, nausea, fatigue, depression and anxiety because of chronic pain and infertility issues. Believe me, friends, it can cause anything, right from pain during intercourse and pain during menses. It can give you multiple troubles, and because of that, patients usually go into depression and they are very anxious whether I will be okay or not. There is currently no known cure for endometriosis, and we are only treating the symptoms of the disease. Early diagnosis is the clutch, and we have to effectively treat the symptoms of endometriosis. If we if we delay the diagnosis, treatment becomes very difficult. So, what is the prevalence? Prevalence is around 10% of the women of reproductive age group globally are suffering from endometriosis. 25 crore girls and women. See, the burden is very, very high. And if we talk about India, it is about 5 crore girls and women who are suffering from endometriosis. But the bad part is that it takes around 7 years when the patient has symptom to diagnosis. I mean, patients keep on having symptoms, but the diagnosis is not made. And it is usually around 7.5 years that patient is being diagnosed with endometriosis. So endometriosis, it is a hormone dependent disorder, and it is characterized by the presence of endometrial like tissue, glands and stroma outside the uterus, which induces chronic inflammatory reactions, and it induces scarring and adhesions, and this distorts the pelvic anatomy. So primarily it is found in young women, but actually it has been seen in all the age group and all the social groups. Patients with endometriosis mainly complain of pelvic pain, dysmenorrhea, dyspareunia. Associated symptoms actually can impact patients' general physical, mental, and social well-being. So they may have irregular menstrual bleeding, continuous spotting, continuous brownish discharge, bowel problems. Then they can have abdominal pain, chronic pelvic pain, urinary problems. Every time they get periods, they have painful urination and maybe blood in the urine. Endometriosis, it is a disease in which tissue similar to the lining of the uterus grows outside the uterus. It can cause severe pain and make it harder to get pregnant. Actually, it can start at a person's first menstrual period and last until menopause. Cause is usually unknown. There is no known way to prevent it, and there is no cure. Only the symptoms are treated either by medical treatment or by surgical treatment. We all know it causes a chronic inflammatory reaction, as I said in the beginning. And because of that, there is scarring, and because of that, there is adhesions and fibrosis, and this distorts the anatomy of the pelvis. So it may be superficial endometriosis, it may be cystic, like big endometriomas in the ovaries, deep endometriosis in the rectovaginal septum, bladder, ureterus, bowel, and in rare cases, even outside the pelvis, like diaphragm, like heart, like lungs, and at many places. So it is not only restricted to pelvis, it can go anywhere. Risk factors: increasing age, early menarche, shorter menstrual cycle interval, prolonged menstrual flow, family history of endometriosis, low body weight, intercourse during menses, and caffeine intake. Excessive caffeine intake can actually be a risk factor. So, what are the causes? Causes, since beginning, we are actually reading this retrograde menstruation, which is the commonest cause of endometriosis. In which in this, what happens? Endometrial like cells being deposited outside the uterus where they can implant and grow. Second is cellular metaplasia. Cells outside the uterus change into endometrial-like cells and starts to grow. And third is dependency on estrogen. So actually, we call it estrogen-dependent disorder, but it doesn't mean that if the estrogen is not there, if the estrogen is absent, that means endometriosis will not be there. But actually, if we do a situation like hypoestrogenic situation, like menopause, just medical menopause, when there are no periods, and then we see that this disease becomes little bit silent, gets on the lower side. So although the relationship is not very much established, but it is said that this disease is known to be dependent on estrogen. So, what is the impact? Endometrioma has significant social, public health, and economic implications. Why? Because of severe pain, patients are missing their schools, their colleges, their office. They feel so much of pain and fatigue that they just cannot go. Because of all this, they have so much of depression and anxiety that again it is a social problem. And because of infertility, again it becomes a social problem. So it's not only a physical problem, it's a very, very important social problems, because they have so much of pain that their personal life gets disturbed. They do not have sex because of painful sex. So it is important to address endometriosis, diagnose it early, and treat it early. So, what is the relationship between endometriosis and infertility? It has been debated for many years that this is important, that patients who are having endometriosis do have more chances of infertility. 25 to 50% of infertile women have endometriosis, and 35 to 50% women with endometriosis are infertile. So, it is quite high. Infertile women are 6 to 8 times more likely to have endometriosis than fertile women. Uh, Endometriosis is one of the most common condition linked to female infertility. As per ASRM, 25 to 50% of women with infertility have endometriosis. Mild to moderate cases may only cause temporary, while surgery to remove the endometrial tissue can help a woman get pregnant. So you see the, guidelines from everywhere: RCOG, ACOG, ASRM, ESHRE, SOGC, fertility nice guidelines. So everybody tries to, even Foxy, everybody tries to give guidelines regarding the treatment of endometriosis, but there is so much uh, to talk about it, and still we do not have a complete cure for endometriosis. That is why every society is coming with the guidelines for the treatment of infertility, for the treatment of endometriosis. So, what is the cause of infertility in endometriosis? One is ovarian tubal dysfunction. That means because of adhesions, the relationship between ovaries and tubes get distorted. There is decreased estrogen production and increased apoptosis of granulosa cells. Then, because of abnormal peritoneal environment, why? Because there is lots of fluid, there are so much of adhesions. and there is increased concentrations of bad cytokines. Then you have dysregulated endometrial function because of the four biomarkers which are necessary for implantation. They get low. That is glycodyline, osteopontin, hoxa 10, and lysophosphatic acid receptor 3. So I mean the four uh, biomarkers which are necessary for implantation, they are decreased in endometriosis, and that is why decreasing the receptivity of endometrium. Then endometrial antibodies are there because of this endometriosis, and they again give you infertility, and endometriosis associated infertility is there because of immunological factors. What are the stages? 1, 2, 3, 4. 1 is very mild, only superficial implants. 2 is little more, and 3 and 4 are bad. Because here you get all kinds of things. You get endometriomas, there are adhesions, you can hardly see the tubes. Both the ovaries are involved, one ovary is involved. You may have rectal nodules, nodules on the rectovaginal septum, bowel is involved, bladder is involved, ureteric nodules are there. So multiple things. Then it is stage 4. Diagnosis, ultrasound, and next is MRI. Laparoscopy is gold standard, and when you do laparoscopy, if you do biopsy, you actually diagnose this. These are ultrasound pictures of clear-cut endometriomas, chocolate cyst. You can see ground glass appearance of the cyst, and this is typical of chocolate cyst. Then you can see some nodules in the bowel area, rectal area. Endometriotic lesion on the bowel of the bowel on ultrasound can be seen like this. See, this is again uterus and rectum, and you can see the big nodule, and this is deep endometriosis. So diagnosis is laparoscopy is the gold standard. Laparoscopy, biopsy, and histopathological examination. So if you are doing laparoscopy, then histopathology, if it comes positive, it is 100% diagnosis of endometriosis. So these are the cysts. I mean, you can see big cyst, just adherent on the ovaries, adherent on the bowel. It's very difficult to make separate them from the bowel. And once you are trying to separate it from the bowel and from the posterior pouch, they get drained, and chocolatey fluids comes out from it. Thick chocolatey fluid. So now let's talk about the treatment, medical treatment and surgical treatment. So are hormonal therapies effective for infertility associated with endometriosis? No, there is no evidence that medical therapy improves fecundity. If it is effective for relieving pain associated with endometriosis. Comparing medical treatment to no treatment or placebo, the common odds ratio of pregnancy is only 0.85%. Hormonal contraceptives, they are good, but again, they are not indicated for infertility treatment, and in severe disease, there is no effect. So, what is the ESHRI guidelines? In infertile women with endometriosis, clinicians should not prescribe hormonal treatments for suppression of ovarian function to improve fertility, because medical treatment is not effective. It rather delays fertility restoration. Medical treatment is effective only to relieve pain, to have regular cycles, to have not to have regular cycles, to delay the cycles so that the patient does not have pain. Young girls, they actually wants only pain relief, then it is very good. But if you are actually looking for fertility, then we should not delay fertility treatment. So first line medication according to ESHRI, progestogens or antiprogestogens, NSAIDs for analgesia, combined oral contraceptives, again very good for to have relief from cyclical pain. GnRH agonist and antagonist both are good. Aromatase inhibitor like letrozole, it is again very good. And this is a very latest article from Frontiers to 2023. So classifications of drug for endometriosis: progestogens, dinogestrol, gonadotropins releasing hormone agonist, GnRH agonist, and antagonist, Elagolix, which is now available in the market. Multiple companies are coming with it, and now actually it is available. So oral antagonist will be, I think the drug of choice for the patients of endometriosis. SKI2496, this is again gonadotropin releasing antagonist. NSAIDs, I said it is for pain relief. EP4 receptor antagonist, selective progesterone receptor modulators are also available. Selective estrogen receptor modulators are also available. Letrozole, all of us know we are using it, but becomes very costly. And then dopamine receptor antagonist like cabergoline, which is again a very, very important drug, and it is actually effective in treating endometriosis, and the small lesions disappear because of this dopamine receptor agonist like cabergoline. So all these things can be given if the patient is delaying pregnancy. If she doesn't want pregnancy, only pain relief, young girls who has been operated once or who doesn't want to get operated, they have small lesions, they have small chocolate cysts, they can opt for these treatments. If surgery is effective, clinicians should perform operative laparoscopy with excision or ablation. Adhesiolysis should be done. It should not be a diagnostic laparoscopy. It should be a surgical operative laparoscopy. Only draining the cyst will not do anything. It should be removal of the cyst wall with laser vaporization, because instead of monopolar electrocoagulation, laser vaporization is better in terms of higher cumulative spontaneous pregnancy rates. In stage 3 and 4, operative laparoscopy instead of expectant management improves spontaneous pregnancy rate. So if you see in moderate endometriosis, if the surgery was done, the pregnancy rate was almost 60 to 70%, while expectant management gave only 33%. In severe endometriosis, there was no pregnancy in expectant management, while in laparoscopic surgery group, it is 52 to 68%. So complete surgical removal of minimal and mild endometriosis improves outcome of subsequent IVF and ICSI treatment. Does surgery improve success? Yes. In stage 1 and 2 endometriosis, undergoing laparoscopy prior to ART, clinicians may consider the complete surgical removal of endometriosis to improve live birth rate. Laparoscopy should not be performed prior to ART in all the women, with only aim to diagnose and subsequently treat in order to improve the result of ART treatment. In stage 1 and 2, surgical ablation is recommended. In patients who fail to conceive spontaneously, ART is more effective. And as I said, surgical resection of the cyst wall or the nodules is actually very, very important. And in deeply invasive disease, it should be resected completely. So let's see the advantages and disadvantages of medical and surgical treatment. Medical treatment, avoidance of surgical complications. Any surgery, you take the patient in OT, there are some complications which cannot be avoided. I mean, there is a risk of surgery, there is a risk of anesthesia. So unless it is really needed, we do not go for surgical treatment. Then the second is avoidance of profound ovarian reserve decrease. Once you do the surgery for big chocolate cyst, there is always a chance to decrease ovarian reserve. No delay in infertility treatment compared to waiting for recovery after surgery. But the disadvantages are persistent symptoms, accelerated progression of the disease, cyst complications, and because of so much of adhesion, there is difficulty in access the ovary during ovum pickup. Follicular fluid contamination may be there during oocyte retrieval procedures, and uh, this is a cause of recurrent pelvic inflammatory disease, and we cannot confirm whether it is endometriosis or it is malignancy. With surgical treatment, advantages are symptom alleviation, histological confirmation, and reduced risk of cyst complications. While disadvantages, surgical complications, profound decline of ovarian reserve, and post-operative adhesions also is there, and possible delay of infertility treatment till the patient recovers from surgery. So, what should we do with the ovarian endometrioma? As I said in the beginning, that if at all we are going to do surgery of more than 3 centimeter endometrioma, the cyst wall should be completely removed and laser ablation should be done. Patients should be counseled about the ovarian reserve, that there will be some possible loss of the ovarian part. There will be a decline in ovarian reserve. Her AMH value will go down. Usually, it has been seen that if the surgery is well done, this all comes back. The ovarian reserve comes back to the same after 3 months or so. So, is IUI is a treatment of choice? Yes, in stage one and two after surgery, IUI is a treatment of choice. Patients do have better pregnancy rate if they are just waiting with medical treatment or they are going for IUI. But for stage three and four, IUI actually has no place. For IVF, going straight to IVF if the age is more than 35, infertility is long lasting. IVF bypasses the distortion of pelvic anatomy and removes gametes from a hostile peritoneal environment. And that is why it is better to go for IVF. Although, if the surgery has not been done properly or the patient is having big chocolate cyst, in that cases, even IVF will not give any results. Better would be go for surgery and then go for IVF. In stage 3 and 4, recommendations are that first surgery and then go for IVF. So, agonist and antagonist, usually, initially we used to think agonist is better, but now even antagonist is the same. It may be used as a reasonable choice for poor responders. The results of IVF in advanced endometriosis is 36% reduced as compared to other indications. So, the results are really poor in endometriosis cases, whether it is agonist or antagonist protocol. As such, in IVF, pregnancy rates are low in patients of endometriosis. So stage one and two, she's 30 years, less than 35 years, we can go for IUI. If stage three and four, age is more than 30 years, less than 35 years, but it is stage three and four, straight away should go for ART. Actually, if disease is severe and the age is also more than 35, then there is no point waiting for conservative management. Just few words about adenomyosis, because we are seeing so much of adenomyosis nowadays. Even young girls, preemies, they are coming with big size of uterus, very bad adenomyosis, severe pain, heavy bleeding, and when you put a TVS transvaginal probe and you see the big uterus with adenomyosis, this is again a very bad thing for young girls, even the girls who are trying for pregnancy, because about 11 to 12% of patients with adenomyosis are infertile. And the effect of adenomyosis on fertility has been assessed by examining its prevalence in infertility in patients or its effect on the outcome of ART. The link between infertility and adenomyosis is still a subject of debate. The association between these two processes is clinically recognized. All of us know, all of us who are treating adenomyosis, who are doing infertility treatment, IVF, they know that it is really bad disease. It's very difficult to treat adenomyosis, because again there is no permanent treatment for adenomyosis. And I mean, you are just giving medical treatment, surgical treatment. If there is very big uterus, you are doing just bit debulking. If there is adenomyoma, you are just taking out the adenomyoma, and you don't know, the recurrence is so fast. अभी आपने निकाला है, next time when you see, the uterus is just the same. So adenomyosis per se, the disease to have adenomyosis, especially in infertility, is very bad. So this is very latest 2023. Again, including medical and surgical therapy or combination therapy, is the same: oral contraceptive, androgenic agents, progestins, GnRH agonist, antagonist. Everything is being used successfully. Although at present time, the later preparations are the most popular medical therapy for endometriosis, that is GnRH agonist, oral GnRH agonist. We are using GnRH antagonist. We are using GnRH agonists like leuprolide acetate injections, goserelin, and nephrolin. Few words about it: that it causes bone mineral density depression, and sometimes this may be irreversible. Since endometriosis is a chronic condition, it is not uncommon for recurrences to occur. Actually, recurrences are very common. While endometriosis remains an enigmatic disease, the introduction of new pharmacological agents such as GnRH analogs and newer endoscopic methods of surgical treatment have facilitated and improved the overall management of this disease. So, we were actually studying and listening about elagolix, that is GnRH, oral GnRH antagonist. Now, because it is in the market, it is coming in the market. I hope the treatment is little easier and patients do have some pain relief. What are the challenges? Because challenges, again, initially also I said that it is mainly affecting social life, personal life, giving so much of depression and anxiety issues. Psychological, psychosocial aspects are actually very high in this kind of disease. So it is important to diagnose these patients, to counsel them, to talk to them, make some groups of endometriosis patients, and it is important to counsel them about the disease, to create awareness about the disease. Media, even we as doctors, we can actually create awareness about endometriosis. So, the management of endometriosis related infertility remains challenging and is a subject of debate. Female age, duration of infertility, pelvic pain, and stage of endometriosis should be considered when formulating a management plan. Endometriosis has been shown to induce infertility through a variety of mechanisms, and the reduction of ovarian reserve is one of the factors most directly involved in decreased fertility. Endometriosis itself contributes to the reduction of ovarian reserve, and surgical treatment further damages ovarian reserve. Therefore, when considering surgical treatment, it is important to make decisions and considerations and the severity of each case. It is also important to share opinions with patients in this process. Medical or hormonal therapy should be used as an adjunct to ART because such therapies themselves have little effect on infertility. IUI is first line method of choice after surgical treatment of minimal to mild endometriosis. In patients with severe endometriosis, IVF can be considered as a treatment option. Physicians should accurately diagnose patients' conditions and provide personalized treatment plan. That is very important, while taking into account the advantages and disadvantages of each treatment options. So thank you so much. Thank you so much, friends, for your patience listening. I'm here. I would be very happy to answer your questions.
Thank you so much, ma'am, for taking out your valuable time and sharing your knowledge on this topic, ma'am. We know that this is a very important topic. I hope that the discussion, the presentation you have carried forward will definitely help all the participants on their practice also, ma'am. As we can see, sir, we have received question, ma'am. With all your permission, shall we take this question? Like I can see the first question is from Dr. Snehali, and she's asking like, ma'am, what are the initial stage of like what are the clinical examination we should do before examining endometriosis in the patient, ma'am?
So, okay, I think it is most important to take a history from the patients. And from the history itself, you make up your mind that this may be endometriosis. Suppose a young girl entered into your chamber and she says, I am having severe dysmenorrhea, and at every periods I have to be admitted or I take injections. आपके माइंड में तुरंत आ जाना चाहिए that this may be endometriosis. Or she says that at every menses I am having painful micturition, I am having bleeding from my urine, so this may be bladder endometriosis, and believe me, it is not uncommon. So examination, I mean, you can just put your hand on the abdomen below umbilicus, and if she is wincing with pain, it may be endometriosis. So the most important is her history. Having severe pain during menses in every period, she has to miss her school, she has to miss her college or offices. Then actually, it should come in our mind that she may be having endometriosis.
Uh, Thank you so much, ma'am, for answering this question. I can see one other question from Dr. Subramaniam. He's asking, ma'am, when is radical surgery indicated in the treatment of endometriosis, ma'am? What's your point of view on this question, ma'am?
Please repeat the question. Please repeat the question.
The question
We
is
were
from
not
Dr.
audible in
Subramanian.
between.
Can you hear me, ma'am? Hello.
Yes.
The
Yes, yes,
question
I
is
can
from
hear you.
Dr. Subramanian, ma'am. He's asking when is radical surgery indicated in the stage of endometriosis, ma'am? What's your point of view on that,
So
ma'am?
actually, stage four, because once you are doing ovarian endometriomas again and again, there is hardly any reserve left. But I am not in favor of radical surgery because that means the patient is in 100% surgical menopause. First thing, second thing, they go into depression, they are into anxiety that I don't have my uterus and ovaries. But if she is having recurrence again and again, she is having severe pain, and you know that she cannot conceive, she has bad endometriosis with adenomyosis, and there are no chances of her to conceive. uh, Radical surgery can be done to relieve, to give her relief from her pain, to have a better life, in sense of that she can be free of pain. Maybe psychologically she is distressed, but believe me, if the patient is in too much of pain every cycle and they know that they cannot conceive, their condition is too bad, then they themselves come and say कि doctor please आप सब कुछ निकाल दीजिए. Although taking out the ovaries is bad at this stage, but sometimes I mean it is necessary.
Thank you so much, ma'am, for answering this question, ma'am. We will be taking one last question from this session. This is from Dr. Rajshri, and she's asking, what is the role of retrograde menstruation in the etiology of endometriosis, ma'am? What's your point of view on
So,
that?
doctor, we are studying it for a long time. All our textbook says the same thing: retrograde menstruation. That's this blood goes deposited in the peritoneum, nearby the ovaries, nearby tubes, and this actually aggravates the chronic inflammatory reaction. Then there is a scarring, and then there are adhesions, and then the process goes on and on. So, retrograde menstruation, his story, we are reading it for a long time. We were When we were students, there was only this story, and second was estrogen dependency of the disease. So these two is the only etiologies or only pathologies which we are studying for a long time, and now cellular metaplasia has come up. Otherwise, the only theory which was there was retrograde menstruation.
Thank you so much, ma'am. Once again, I can see Dr. Snehali has written, thank you so much, ma'am, for answering. Wonderful presentation. I hope she's
Thank
really
you so
enjoy.
much.
Yes, ma'am. And as I
Thank
can
you.
see, there is no more question, ma'am. I hope you have done justice to this topic, ma'am. So, though there is no more question, as there is no more question, with all your permission, shall we conclude this session, ma'am?
Yes,
Yeah.
sure, sure,
Uh,
sure.
Thank you so much, ma'am. And we would like to see you in future also with different topic,
Yes,
ma'am. Till then, take care
yes,
of yourself. It was really nice to have you,
definitely,
ma'am. Take care.
definitely. I'm always regular on IJCP. Thank you.
Thank you, ma'am. Thank you. Bye.
Okay.